it's after 8 and seems like most people are online. Good evening. The topic of the tutorial this evening is the approach to management of bone defects. Now, management of bone defects is something where there's no clear guidelines for. It's an area where you should have an approach. You should have be able to perform different techniques, and you often have to be a little bit creative. So these are some of the most challenging cases in orthopedics, and also some of my favorite cases to treat, because as I said, you need to have multiple tricks up your sleeve and you need to be creative, and there's no clear guidelines that guide you on how to treat it. So we're going to just spend a little bit of time on the definition of critical bone defect, discuss the different options available, and how I decide which option to select for specific clinical scenario. So this is an editorial written by Nando and Professor Hamish Simpson, who is the editor of Bone and Joint Research, and on the reconstruction of critical bone loss. And they basically say that finding a solution for reconstruction critical bone loss that's easy and reliable is the holy grail of orthopedics. So more important than other things like arthroplasty. So let's start with a definition. So first question for me is, what is a critical bone defect? Brad, your name comes up first on my screen here. What's your definition of a critical bone defect?
I don't have an FC Orth, Prof, so I don't have my own definition, but I'll quote yours.
Okay.
Basically, it's a bone defect that will not heal without an intervention.
Yeah, great. That's a definition that I like. There's various definitions used in the literature. You know, some sources use a defect of more than 2 centimeters, but you know, very seldom will something like that heal. You know, even smaller than that heals spontaneously. And critical bone defect, which should also include partial bone loss. You know, if you have a tibia fracture with loss of cortical bone and you just have sort of 2 spikes balancing on one another, except for in pediatric cases, it's extremely rare that would heal. So critical bone defect also includes cases where there's partial bone defect, and we usually like to talk about circumferential loss of more than 50%. So if you have less than 50% cortical contact, you should basically have a strategy to address that bone defect from the beginning. So for me, the best definition is any bone defect that won't heal without intervention. And there's, of course, many different defects, traumatic causes for the defects, traumatic, post-traumatic infection or non-union, post-tumor resection, failed arthroplasty, or some congenital cases. So just a few broad considerations. You should always think of your host, both the local situation of the limb involved, as well as systemic involvement and other injuries. You know, you're not going to tend to the, segmental bone loss if there is a life-threatening injury that needs to be treated. You need to look at the soft tissue, and you also need to look at the resources that's available. And the size of the defect is really important. Now, in plastic surgery, they talk about the soft tissue reconstructive ladder, and this is a reconstructive options with increased complexity used for different size defects. So I like to think of the bone reconstructive ladder also according to the size of the defect. Now, these are all just options, and they're not all appropriate for any limb segment, but just as a general rule. So for me, for bone defects of less than 2 centimeters, you can really do whatever you want. You can just shorten, you can maintain length and do simple cancellous grafting, or use more complex technique. You don't have to do something very fancy. It should heal reliably with a variety of techniques. 2 to 4 centimeters now. Just cancellous bone grafting of defects of more than 2 centimeters has a very high failure rate, and you can still shorten, but you should consider lengthening either simultaneous or later, or you can do techniques like the masculate technique. I'll discuss the masculate technique a little bit later. For me, only in specific limb segments with good soft tissue cover. But if you would like to do masculate with the tibia, you should only really consider it for very small defects. 4 to 8 centimeters is really the ideal length for bone transport. Again, as I said, masculate you can consider in limb segments with good soft tissue attachments. More than 8 centimeters, we talk about bone transport. Long bone transports. We'll discuss it a little bit in more detail later, but here you're going to have patients in a frame for a very long time. You can consider hybrid techniques to cut down on the fixated time, and also should think of vascularized graft or intercalary replacements. I think any bone defect of more than 12 centimeters, you should always strongly consider an amputation, and you can still do bone transport, but you should consider a hybrid technique just to make the treatment time acceptable. For these big cases, you should always pick, patients with a good surgical host status and also continuous access to care, because you obviously need, you often, specifically for bone transport, need multiple follow-ups, reliable follow-ups. Otherwise, the chance of success is not very high. So you need to aim for the best possible function in the shortest possible time frame with the resources that you have available. So I always like to think of it this way: is the limb worth saving? In other words, if you have a critical bone defect in the femur, in a limb with a distal destroyed joint, or another pre-existing abnormality, it's not necessarily worth going through the reconstruction. You should, in these complex cases, always mention and consider optimizing the host, specifically looking for reversible host factors that can influence your outcome, and then decide on the treatment strategy for the specific situation. There's some different options, whether it's acute or chronic, and also which limb segment is involved. So again, the decision in acute trauma with a manual extremity on whether to address the bone defect and the injured limb for limb reconstruction versus amputation is the degree of injury, the expertise available in limb salvage, that's both in orthopedics and in plastics, the timeline of such a reconstruction, the amputation options, and then the patient's access to prosthetic care if you consider an amputation. I'm not going to spend too much time on it. I know I'll always hammer away on this topic, but like I said, you should really select appropriate hosts. Otherwise, you're going to put patients through a lot of surgery without a significant chance of success. So, like I said, there's no clear guidelines. There's a lot of different techniques. I'm going to run over the different treatment options as I see them, and then we'll go look at specific scenarios to say when I would use what. So the first thing, as always mentioned, is spontaneous healing. Now, this is rarely used in adults, or rarely happens in adults, mostly in pediatric cases, and it relies on an intact periosteum. And in children, large bone defects where there's bone missing but retained periosteum can heal spontaneously. Unfortunately, we're not so lucky in adults. So the first treatment, and this is your friend in acute trauma, is acute shortening. I always get asked, how much can you shorten a limb? And this is something that's mentioned in an old textbook without really ever any good evidence or proof. Numbers used is always 2 centimeters or 4 centimeters. So I think for me, the correct answer is a limb can be shortened as much as it can tolerate. Now, you can usually achieve, or the limb can tolerate, larger shortenings in acute trauma when the tissue is elastic and is elastic and can tolerate larger shortenings. I mean, I've certainly shortened limbs acutely in acute trauma, for instance, in the femur, 10, 15 centimeters. It's more difficult in the tibia and the forearm because there's two bones and the soft tissue is quite asymmetrical, so you can struggle to close a wound afterwards, and it's much harder in a chronic situation. So in a chronic situation of sort of stiff tissue, you can seldom shorten more than 2 centimeters or up to 4 centimeters, not because you're not allowed to do more than that, but it's not technically achievable. Acute, you can usually do much more. Of course, in the lower limb, you should consider, if you do shortening of more than 2 centimeters, you should consider lengthening at a distant site, either at the same time or at a later stage. But this is an example of one of sort of our typical patient, a 29-year-old PBA, in a patient that's not a good surgical host, comorbidities, smoker, and for him, you can see here that he sustained a distal grade 3B open tibia fracture. Multiple bony fragments was missing at the from the injury, and this is after the first debridement. You can see the loose cortical fragments is removed, and the simplest solution here was a sort of further debridement, squaring of the ends to achieve adequate bone contact, and that allowed primary closure of the wound as well. And we converted that the patient to a hexapod to fine-tune the position and achieve some compression, and it healed uneventfully. So very simple solution for what in essence is a 3-4 centimeter bone defect in the distal tibia with a soft tissue defect that heals reliably. Now, in a patient where you would want to lengthen, you can do that either at the same time or at a different time. So this is an example of acute shortening with simultaneous lengthening at a distal site. So we'll discuss the differences between that and bone transport in a second. So this is a 27-year-old polytrauma, again with a bad open distal tibia fracture and some bone loss. You can say there on the formal x-rays, there's a large segmental cortical piece that's loosed and vascularized and appropriately debrided and spanned in the next fix. So in her case, we again cleaned up the ends, squared off the ends, shortened to achieve good bony contact. This is a large shortening, probably around 6 centimeters, and we converted her to a hybrid frame with a hexapod across the shortening site to compress as well as correct the alignment and a proximal tibial osteotomy. Now, the benefit of shortening with simultaneous lengthening versus bone transport. In bone transport, you maintain the length of the limb segment. You do a osteotomy, and now you move that middle segment down. So in other words, healing at the initial treatment focus only start once the bones dock. With acute shortening and distant lengthening, you from the beginning have your first treatment focus in contact, and healing already start while you start lengthening. So in her case, we lengthened the 6 centimeters to give a length back, and you can see progressive consolidation of the regenerate and eventually a united tibia. So bone grafting for a bone defect, while autogenous bone graft obviously can be harvested in different forms, just simple cancellous or structural or cortical bone graft can be harvested, and then bone graft can also be vascularized. Just looking at cancellous bone graft, initially the commonest site is the iliac crest, but you can really harvest it from any metaphyseal bone segment. You do get specific little harvester cores from various companies where you can harvest if you only need a small volume, and then the reamer irrigator aspirator is also a useful tool. So just using cancellous autograft for segmental bone defects, you should only do in small defects, up to 2 centimeters, I would say. If used in bigger defects, the graft just resorbs, and you need to combine it with membrane or cages, or use a structural graft in larger defects. Now, with the withdrawal of Depuy Synthes from the South African market, this is also one of the products that we lost, which is very useful when you need a larger volume cancellous graft than you can get harvesting from the iliac crest. This reamer irrigator aspirator system is very useful. Firstly, you can harvest large volume, like 50, 60 cc's of bone graft by reaming the femur and sucking out the bone graft. And also, there's some comparative studies, as you can see here, showing higher levels of important proteins like BMPs and better osteoconduction, and also more living cells in the rear bone compared to iliac crest bone graft. Mention allograft. The main reason I want to mention allograft is to say that allograft should only be used as a void filler and should never be used in segmental bone defect. You cannot use a dead piece of bone for a segmental bone defect and expect healing. Again, in a similar fashion, the synthetic bone graft substitutes. Now, I would say with the biphasic grafts like the calcium sulfate hydroxyapatite combos like Cerament or Proteins, there are some series showing small defects of maybe up to 1 centimeter where that's successfully treated with synthetic grafts. I would say that's obviously the exception. Synthetic grafts are really useful in void fillers and specific in infective cases to deliver local antibiotics, but they should have no or very limited use in segmental bone defects. Now, vascular graft is something that's always mentioned. And of the best known vascular graft is a vascular fibula. Now, firstly, vascular fibula transfer is a very technical, demanding operation. You need microsurgical expertise. All of us in South Africa have quite poor access to plastic surgery in general, and then even more so microvascular surgical skills. However, vascular graft is a viable option for large bone defects. In the lower limbs in adult trauma, it is not my first choice, and the reason for that is you replace a large bone like the tibia with a thin fibula. There's a high union rate, as you can see here, 80% quoted in this paper, I think of more than 100 cases, but there's a high complication rate in lower limb cases, and this is specifically with fractures of the fibular graft at a later stage. And it can take 3 or 4 years for the fibula to undergo adequate hypertrophy for the patient to weight bear. It's different in pediatric cases. I'll show a case now, obviously smaller and have less of a weight, and it works well. And also sometimes in low demand patients, like some oncological reconstructions, where patients are not that active or that have that high demand, and there's a lower complication rate. So this is just one of my cases. It's a 14-year-old boy that presented with a pathological fracture following a chronic osteitis. No real sequestrum, no real involucrum formation there, and you can see massive sequestrated tibia. I think we resected 19 centimeters of his tibia. Now, this is even at the upper limit of the fibular graft that you can harvest, because you can imagine you can't go all the way to the ankle distally. So this is just some intraoperative pictures with the plastic surgeon where the fibula is harvested with the vascular pedicle. In the middle is the microvascular anastomosis, and then that is transferred to the bone defect. These pictures are immediately post-operatively with a plate is combined with a plate. That's obviously adequate protection. Now, with a plate, there's obviously some shielding of the fibula, and it can take a little bit longer to hypertrophy. But with a frame, it's very difficult to know when you can remove the frame, and often, significant complications of fracture after removing of the frame. And this is the patient at 6 months. You can see proximally and distally, there's very good hypertrophy of the fibula already, and no signs of metal wear failure, and very good functional result. The induced membrane technique or masculate technique is another technique that can be used for reconstruction of segmental bone defects. That can be very useful. It's a staged procedure where the first stage is described on stabilizing the defect and inserting a cement spacer. Now, the original masculate series included all cases with the use of external fixator devices, and then 6 to 8 weeks later, the membrane is incised, the spacer is removed, and the defect is filled with autografts. Again, other series have shown that you can dilute the autograft to allografts in up to a 1:3 ratio, but usually when I do a masculate, I use purely autograft. If I need more graft than is available with harvesting from the iliac crest, I use the rear system when it was available. Now, since then, there's been many modifications or other series of people combining internal fixation. So for me, whenever I do a masculate, I only do it in bones with good soft tissue cover, and I usually do it in combination with internal fixation. But because the problem with the masculate technique is, firstly, the results is quite unpredictable, and also the time to union is quite unpredictable. So masculate original series had 35 patients, and they achieved a union rate of 90%. Now, initially, this was published in French, and I think a lot of information was lost. So no one's been able to replicate this high success rate from the original series. I think in the original series, they were included up to defects of more than 20 centimeters. And subsequently, we've learned, from the unit themselves, that in many of the cases, the patients had multiple bone grafting. I think in this original series, some cases even had up to 8 episodes of bone grafting. So it's not necessarily a single solution. And again, in a lot of the treatment techniques we use, your time for your reconstruction is related to the size of the defect. In the masculate is not the case. In other words, you can wait a very long time, and then if it doesn't unite, you still have to go back to other techniques. So for me, I only use the masculate, or very seldom use the masculate in the tibia, except for very small defects. Using a segment spacer for a partial defect can be quite useful with planned grafting later, but that's not, strictly speaking, a masculate technique. Works well in bones with good soft tissue like the femur and the humerus. So this is just an example of a case of masculate technique, young polytrauma patient, and with multiple injuries, as you can see. So the left femur is probably the simplest. That was treated with a plate on the index procedure, and he had a retrograde nail. He had about a 15 centimeter segmental bone loss in his femur. So he was shortened as much as we thought the limb could tolerate, maybe 6 or 8 centimeters, and that left a separate residual defect of also about 6 or 8 centimeters. The segmental tibia was treated in the Lizaroff frame. Here you can see the retrograde nail with the cement spacer around it. And then at 6 to 8 weeks, the cement spacer was removed and Kinsella's bone graft was inserted. As you can see here, the progressive x-rays, there's more and more calcification in that area, not quite union yet. In his case, because he still had shortening, we went and we took out the retrograde nail, put in a precise lengthening nail, did another osteotomy, and lengthening the residual amount of shortening, which is about 5 or 6. And in that time, the area of the mascula also further consolidated, and eventually, after the reconstruction, he had equal leg lengths with a united fracture. So bone transport, utilizing the technique of distraction osteogenesis as described by Elizarov, is really the mainstay of reconstructing large segmental defects, specifically in the tibia. The technique in general relies on a low energy osteotomy. The one that's mostly used is a pre-drilled osteotomy as described by Di Bastiani. Other alternatives is using a jiggly saw. I don't like that because you need to pass the jiggly saw around the bone and make sure you don't entrap any neurovascular tissue. You need to observe a latency period, and this is for the healing to start. In the scribed literature, this can be anything between 5 and 14 days. And then you need to start transport at a rate of up to 1 millimeter a day at a rhythm of 3 to 4 divided doses per day. Now, in Elizarov's initial experiments, they settled on 1 millimeter a day and 4 divided doses, because this is where there was a high, an acceptable amount of bone formation versus fibrous tissue formation. If you go faster, there's more fibrous tissue formation, and then also one can do either close or open docking procedure at the time of docking. I'll show that in the cases now, then you'll be able to understand better. Now, there's a few rules that you can use on the treatment duration. I think one of the good things of bone transport is that the healing time is relatively predictable in its relation to the length of transport. So you can say consolidation phase is usually about twice the lengthening phase. So if you transport for 5 centimeters, that is 50 days of adjusting, and then another twice that for healing. Or you can use a healing index of 1 to 2 months per centimeter. The 2 is usually a maximum that you'll give patients. So in other words, if you're doing an 8 centimeter defect for transport, you can say the patient would be in a frame for up to 16 months. It's a very long time, but at least that's a predictable time frame that you can give a patient compared to masculae where you wait and you wait and you wait, and then you're not sure. Maybe I must just stop there before I show some cases of bone transport and just ask if everyone understands the concept or have any questions around bone transport through distraction osteogenesis, or any other questions of anything I mentioned up to now. Okay, you guys also welcome to interrupt me at any stage. So this is a case of a bone defect secondary to resection of the septic non-union. You can see here, this is just after the spacer was removed, the proximal osteotomy was performed, and now you'll see on subsequent x-rays, this gap gets bigger. You can say compared to the lengthening shortening, here the overall length of the tibia is maintained, and this middle segment is transported down until it docks. You can say dock. Now, closed docking refers to you simply just adjusting the frame till these 2 segments meet in the middle, versus open docking, which means as you get closer to docking, you do an open procedure where you open that area, you sort of freshen up the bone ends, and you put some cancellous graft in it. Now, specifically in long transports, it is a problem that, the soft tissue, specifically in the tibia, can almost fold into the defect on the subcutaneous medial border. Now, always in the tibia, do an open docking procedure, and just to increase the success rate and decrease the soft tissue problems. So here you can see in that same case at completion, he had a little bit of a regenerate cyst, but still made good regenerate and healed, and the docking site healed nicely. So transport in the tibia can both be proximal to distal or distal to proximal. Proximal to distal is always preferred because your osteotomy is in the proximal metaphyseal bone that makes better regenerate, but can be distal to proximal, as you can see here. So large proximal metaphyseal defect with transport distal to proximal. Here you can see at the docking side, there is the regenerate, and that same case at healing. Has anyone heard of the Papineau technique? This is something that's really historic, although every now and again you have a case where you don't have any soft tissue cover options and amputation is not an option. So Papineau described open bone grafting, and then just simply treat it with negative pressure wound therapy on top of the cancellous graft until soft tissue granulation. So basically back assisted closure over cancellous graft for a defect. I have only done this once. I wouldn't sort of recommend it as a first line option. It takes months and months and months and months and months. And again, it's not predictable, but it is an option to just be aware of. Now, when we refer to hybrid techniques, these are usually techniques that's aimed at decreasing the time that the patients spend in the circular frame with bone transport. And these include bone transport followed by internal fixation, either of a nail or a plate. And this is usually my preferred option. So either you transport and then you mostly nail. It can be lengthening over a nail. I'll show a case. Lengthening over a nail is always something that sounds quite attractive. And then there are also some other cases, some other techniques, including the use of a precise nail. So I think you guys should all be aware of the precise lengthening nail. That's really the sort of gold standard for lengthening specifically the femur. You can use that in conjunction with the plate. And there's also soon available a transport nail where you can do all internal bone transport. The problem is it's incredibly expensive. It's not available in South Africa. I think at the moment, the transport nail in America is in the vicinity of close to 300,000 Rand. So almost double the price of a normal precise nail. And usually, it still has significant complications. So one can achieve similar results with a much more cost-effective bone, reconstruction technique. This is a very nice little trick, should I call it, that can be used in the femur. Now, again, this is I'll show a case now that I did. But nowadays with the precise nail, I think with femoral defects that you can shorten, it's just the simplest technique to resect the bone, shorten nail, wait for the bone to heal, and then go and swap the trauma nail for a precise nail and lengthen the bone, as I showed in that other case. But if that's not available, or you need to do something else, this is a case that you can see with the segmental femur fracture that's not united. There was a previous nail breakage with an attempt at an exchange nail where just a new nail was inserted past the other nail. So what we did in this case was resect the non-union, because that middle bit of bone was very sclerotic and didn't look like it was viable. So with the rail, you can see here acutely shorten that area, do another osteotomy. And what you can see here is we inserted a retrograde nail, knocked it out the piriform fossa, and left it in the soft tissue for how much you wish to lengthen at the osteotomy site. And if you did did this just with an external fixator, the patient would have to be in the external fixator for, months or even a year, as long as it takes to unite. But now, you can lengthen in the subtrochanteric osteotomy area, and you simply lengthen that area of a rail until the retrograde nail is in the femur. Then you take the patient back to theatre, insert 2 locking screws, and remove the X-fix. So a nice technique. Although, as I say, this is really historic. I've did this case, but this was in the days before the availability of the precise nail. In this case, now it would have been simpler to just shorten the nail, let it unite, and then swap it for a precise nail. But that's still probably more expensive. So it is nice to, like I said, have more than one trick up your sleeve. So another hybrid technique is lengthening over a nail. Again, as I said, my preferred technique is lengthening or transport and then nailing. And the reason for that is that it actually adds a lot of complexity of lengthening over a nail. So this is a really badly mangled tibia. Initial surgery was a nail, large spacer, and a free flap. So this is after the spacer was removed. Again, it's well over 10 centimeters defect in the tibia diaphysis. You can see here proximal corticotomy around the nail. That's technically quite difficult. And then a much simpler frame, because obviously the nail holds the proximal segment, and you just drag the segment over the nail. Now, it looks easy in theory, but you can see here from the picture on the right how the wires bend. Obviously, if the direction of your transport is not 100% aligned with the nail, it creates a lot of friction. And in this case, actually 2 or 3 centimeters short of the docking, we could not move that segment anymore. You can also see that despite some blocking screws behind the tibia, also had some collapse into valgus and procavatum. So it is a technique to know about to cut down on fixated time, but it adds a lot of complexity, and sometimes it's easier to just do the transport, dock, and then you can always remove the frame and insert a nail. Intercalary replacements, really something that is not ideal for trauma patients, especially young and active one, but an elderly, very poor, very low demand patients or poor hosts. Intercalary endoprosthesis can be considered. These are very high complication rates, and because obviously the metal will eventually fail. Specifically in oncological patients that's old and low demand, this can sometimes be considered. So another little exciting, which is also exciting reconstruction that's classified as an intercalary replacement, is the use of titanium, custom titanium 3D printed truss cages. So I first learned of this technique when Kevin Tetsworth, which is a limb surgeon from Australia, presented this at a meeting, and I was immediately very interested. He presented his first 5 cases and a further follow-up of cases, and I'll show you the technique now. And the truss cages was attractive because it had a short treatment duration, allowed early weight bearing, high success rate, low complication rate, but the biggest concern was cost. And I think in his original series, the truss cages, the average price was over $20,000, which of course is astronomical cost for our environment. Now, truss cages is based on an engineering principle of octet truss lattice. Now, this has a very high strength to weight ratio. In other words, you need very little material for a very high strength construct, and it's efficient in carrying compression and bending load. It's extensively used in engineering of bridges, as you can see here in Manhattan Bridge in New York, because it maintains a degree of elasticity, and it's obviously much cheaper than building this bridge in solid concrete or steel. And then in the human cases, it has the added ability that you can insert bone graft into the porous structure. So when I did encounter a case that I think would be suitable, I discussed it with the engineers from the local LRS implants that make custom oncological implants, and they agreed that they could make the case, and this was they could make the cage, and this is 3D printed just like they did in the original series. You can see it takes some designs. You have a CT scan of the patient. So this was the first patient that we did. This was an adult that presented with a pathological fracture and chronic osteitis, and after resection had a large segmental bone defect. Now, firstly, I try to avoid X-fixes of frames around the femur. It was also a large defect, and I thought this patient would be perfect for reconstruction. So this is the CT that the engineer used to plan. Being our first case, we had to make absolutely certain that it is going to be successful. So this is the planning from the engineering software. We printed a plastic model and got the nail that we intended to use in to make sure that it fits through the middle, and then the final product was printed, the titanium one on the left, and this is a intra-op trial that you can just make sure that your cuts of the defect is adequate. That is very useful. So here you can see the patient post-op. So we've inserted the titanium truss cage, removed the spacer, and fixed it with a intramedullary nail. So firstly, no early complications with infection, and at follow-up, you can see that there's bone formation around the truss edges and also consolidation within the truss cage. So cautiously optimistic. Ahmad published our first 9 cases that we did, all successful without any major complications. Initially all femur and all diaphyseal, but later 2 tibial defects as well. Specifically, bone defect orthodesis cases can be problematic, so that's where this can be useful. Still reluctant to use it for a diaphysis in the tibia. Firstly, the tibia frames do well. Like everything, I can expect that you'll probably have a higher complication rate, specifically infection and soft tissue in the tibia when compared to the femur. So with 9 cases, and the most impressive thing with this treatment is that the sort of healing time or time to functionality is not related to the treatment defect. So the biggest defect in our series, 200 millimeters, so 20 centimeters, and all the patients even after a couple of weeks, able to mobilize independently because the truss cage gives a very good initial stability. So this is a couple of intra-op pictures. As you see, removal of the cement spacer, inserting the trowel to make sure that we don't need to trim the bone a little bit more. Back the truss cage with the harvester's cancellous graft, and then insert it in the defect, and then insert the nail. Union, we've learned, can be quite difficult. So we talk about functional union. For functional union, obviously walking with physiological load without any symptoms. Some cases made exuberant callus, as you can see here, a big bridge of callus. But the most sort of consistent healing pattern was just this, that the edges of the truss is sort of surrounded with bone, and there's also a little bit of bone visible through the truss, but the patient being completely symptom-free. Subsequently, I think I've done 13 cases in total, and again, touch wood, and no major complication. So functional time to union, so in other words, all the patients who are off crutches functionally taking weight before 4 months, and there is no difference or no correlation to the length of the defect in the treatment, which can be useful as well. And also the nicest thing about this, having it locally made, the mean cost was 42,000 Rand. And this is a lot of money. I'm not saying it's not a lot of money, but if you compare this is like half the price of a new circular hexapod frame. So you obviously still have to add the additional cost of the implant that the nail you fix it with, but it is not that high, and obviously much cheaper than the internationally made ones. This is the upper limb case. So here you can see a segmental sort of bone loss case was treated with a humeral nail after a gunshot. The nerve united. Amazingly, this nail lasted the patient 13 years, so she had good function for 13 years, despite the large segment of bone missing, with just a nail holding a humerus. But eventually, the nail broke, as you can see there on this previous X-rays, and then that was revised with another nail and a truss cage, and she did very well afterwards with good function. It also allows you to be a little bit creative. Some of you might have seen this case if I showed it at a conference or somewhere else. This is a sort of a disaster where it's a youngish, very active woman. She's actually a firefighter that had a segmental femur fracture, and the distal fracture was opened with some bone loss. She was treated elsewhere with a cephalomedullary nail, and then she presented like this with failing of a proximal fixation of the neck and a sort of an unaddressed bone defect, and all of it infected. So a bad fracture-related infection with a proximal and a distal infected non-union. So who has any creative plans? I see there. Francis, have you seen me show this case?
I think you asked me this one last time, Prof.
Did I? Okay, cool.
I think so.
Let me pick another name. Someone that hasn't been there around that long. Skalk Klopper.
Me.
Have you seen this case, Skalk?
I don't think I've seen it before, but
Okay, so
although I might have.
What would you do?
Yeah, so in this case, I mean, we're looking at the bone defect in the diphysial distal third of the femur that currently has that the antegrade nail with cephalomedullary locking and distal screws inside too. I couldn't see nicely at the proximal, was that also non-union of the femoral neck?
Yeah, so you can't see it here, but there's a large hole here in the lateral femoral head, and there's sort of a vertical fracture that's basically failing. There's more images, but already a lot of pictures in the talk. So, but it's basically cutting out and falling apart, and it's septic both at the hip and at the distal side.
Sure, yeah. So real complex problem to deal with. So essentially, we have a bone defect in the femoral neck, femoral head that's also septic. It's not amenable to further fixation, and I think the proximal aspect of the femur will need replacement. So either arthroplasty or even proximal femur replacement, and I mean, that's the issue dealing with proximally. Distally, then there's also a critical bone defect where that's all you said is also septic. So yeah, that's also infected. So you'd first want to get control of the infection. So you'd probably consider removing the fixation or the intramedullary nail and the screws, excising all dead, devitalized or an infected bone, getting temporary stabilization of fixation and a spacer in the defect to reconstruct at a later stage, and then treat with culture-specific antibiotics to get control of the infection. Once you have control of the infection, you'd want to then address the defect or the bone defect that you left with. Yeah, and in this case, I think proximally you'd then have to you'll have to lean towards arthroplasty, or you'll have to replace the proximal joint because you're left with no more no more joint there, and distally you'll have to get a graft or a diaphyseal graft to get it to heal. So I think maybe a retrograde nail with a titanium truss cage and bone graft, and then a total hip replacement proximally would be the
Perfect.
answer.
That's what we thought. That's what we thought as well. So anyway, just like Nanu described, the cover-up test of segmental fractures, so really two problems. So we thought proximally really needed two-stage revision to arthroplasty, distal, distal defect. The best would be to do a stage truss cage. So this is sort of a custom spacer, which is a molded spacer like you do for PJIs. But the problem is that short femoral segment in the middle. Can't see it so well on the Scout CT, but we sort of wedged space of the total hip into AO slotted nail, a bird locking holes in there so that we can lock it and cover it in cement, and then just cement spacer, and then planned our second stage, which was then basically a cemented total hip replacement on the top, and an old supracondylar retrograde nail that's not really available anymore, but we managed to source one across that area. So she did well initially, infection free, and she's more than 12 months now and clinically doing very well, but time will tell, like I said. So is this the Holy Grail? Well, I think
can I just ask,
yeah,
sorry to interrupt, I just wanted to ask then, at the second stage, did you do a single sitting
yes,
retrograde nail and then arthroplasty?
yeah. So we did this case together. I met Tom Hilton myself. I'm not an arthroplasty surgeon, so we did. We didn't think, because you're going to take that nail out, and then the distal one is unstable. So, and this is another tricky scenario, because doing a posterior approach hip in the supine position is not easy, and doing a retrograde in the lateral position is not that easy. But Tom won the arm wrestle, so we did the second stage, removed the spacer. Tom did first did the second stage of the hip and the lateral position, and then I had to do the retrograde nail and the truss cage in the lateral position as well. So we did the two first stages in one sitting, and also the two second stages in one sitting. Cool. So, again, by no means I'm saying this is the solution for everything. It's just another option that you have. It seems to be effective in selected cases at an acceptable cost, and it is really very highly customizable. And for me, it's sort of the first choice in segmental bone loss in adult femurs. It's just a very brief word about amputation. Obviously, in long-term, amputation is more expensive than limb salvage because of the cost of the prosthesis. I'm a big fan for amputation, specifically in poor hosts, but some things to take into consideration. If you look at the study looking at the quality of life of amputees, and the biggest prediction, or whether they're happy, is whether they have access or the use of a prosthesis. So, when you offer an amputation to a patient, you should consider whether the patient will have access to prosthesis, because if not, then a limb salvage of even an inferior result would be beneficial. There's very little published about amputations in Africa, but there's a paper from Nigeria that showed only 16% of patients, of 87 patients that had amputations, eventually got a prosthesis. Great. So this is sort of just an overview of the different options that I consider when I have segmental bone defect. I've got a few more cases just in specific scenarios to show, or when I use what. Is there any questions or comments from the audience thus far?
Hi, Prof. It's Francis.
Yes.
I wanted to check, have you ever used, or would you ever use bifocal bone transport for longer tibial defects, perhaps? I've combined it with nails or other things to shorten the frame time maybe means you don't consider it anymore, but have you ever done that, or would you?
Yes, absolutely. So I think I've never done trifocal, but bifocals transport I have done. For those not familiar with it, that means, let me go back to a case there. There's obviously aim for large transport to cut down on time. I'll add that to my list of procedures that I've only done once or twice to have the pictures and would not easily do again. And just the reason for that is it adds a lot of complexity to the frame and to the treatment, and it increases the complication rate. And if you look at papers, it does not necessarily reduce the overall treatment duration. So just to show you a bone transport frame, let's go back to distraction osteogenesis. So here, you see there's an osteo. Maybe this is not so good example because this is done with a stacked hexapod. So let's go back to one of these cases. Okay, so now, in other words, you have, the shortening side, they have an osteotomy. So for that defect, defect in the middle of the diaphysis, you would do an osteotomy proximally and transport that way, and do an osteotomy distally and transport that way. So it adds a lot of complexity to the frame, and because you have two osteotomy sites that needs to heal, there's also an increase in your complication rate. It's definitely an option. So like you say, it's something to consider in large defects. But I often rather use a single transport site, and I try and cut down on the fixation time by just after docking, if the soft tissue look good, to insert a nail, and that cuts down on the fixated time as well, and is sort of more predictable and more reproducible than bifocal transport. But yeah, like I said, bifocal transport definitely an option. Any other questions?
Yes, Prof, can I ask?
Yes, sure, go for it.
So I'm just wondering, let's make it a difficult sort of length, around about 4 centimeters of loss. You're getting there acutely, it's the first trip to theater, 3B injury, and now you realize that you're losing about 4 centimeters of bone. But if you were to acutely shorten, let's say it's a tibia or femur, you can then get the soft tissues closed. And then you're thinking, okay, but now if I can get the soft tissues closed, I can actually nail this. Let's make it a tibia. What would be, do you think is it becoming too risky, our nailing indications there? Or do you think you're burning any bridges?
No, I don't think so. I think if you're very certain, often in these cases, you should just be very happy with your debridement, that you've defined the zone of injury, and very importantly, that you can close it when you shorten it that much. Now, shortening sounds very attractive for soft tissue defects, but you need a very specific wound. So if you have a longitudinal wound, and you shorten, you just end up with like a star-shaped wound, and it's very difficult to close with a large shortening. So the wounds where that works very well is like a horizontal wound. So if you have a large horizontal wound, where you can cut sort of an ellipse out, that is very well treated with shortening. So if you have the ideal case, absolutely, there's nothing wrong with shortening, nailing it. Often, unfortunately, in these cases, there's high degree of contamination as well, which is probably the one contraindication for us for using immediate internal fixation and closing the wound. But if you have the ideal case where you have a sort of horizontal wound rather than a longitudinal wound, and it's not contaminated with a bone defect, you can nail it, you can shorten it and nail it, because then you can always go and swap out the tibial nail with a lengthening nail in the future.
Okay, thanks.
Okay.
Hi, Prof. Sorry. Yeah, Ed
Yes.
from Stellenbosch.
Yes, Ed.
Question.
Just correct me where I'm wrong, Ed. If I
No, it's excellent. What did I want to say? Just the first question that I had was, you mentioned that your preference for your bone segment transport was to transport and then nail. I just wanted to know, are there any considerations when nailing through regenerate? Is that something that is there any special consideration? I know it's quite sensitive and valuable tissue there, so yeah.
No, that's a very good question. So firstly, I think regenerate responds very well to the stability of nailing, and it really is. If you have regenerate problems as well, nailing it really accelerates the healing. It's not rigid, so you can easily nail through it. Of course, there's no cortex that will guide you, so you just have to have special attention. You know that you don't exit the canal. One important thing when you convert a transport to a nail is that once you take the frame off, that sort of segment rebounds. So you often have to provisionally fix the docking site, or at least have some healing there before you nail it. Or if it's acute, add a little plate to hold it at least temporarily. Otherwise, it will jump back. In the non-union cases, there's often the docking site that's a little bit more problematic. I'll show I'll show a case now, because that can be quite sclerotic to cross. But nailing the regenerate is no problem, and it really responds very well to nailing.
Cool. And then the second question that I had was, I see that a lot of your bone segment, or your bone transports rather, you're using stacked hexapods. Is there a reason for that preference versus your kind of normal elongating struts? And
I'll show you my preferred technique. So there is one case here where there's a stacked hexapod. I actually don't use a stacked hexapod routinely. I have used it once or twice. I think that's unnecessary complexity. I do like a hexapod segment over my docking area. The reason for that is specifically in long transport, you need an extreme high level of accuracy with your application of your Elizarov, because you're just transporting in a straight line. And if you're slightly off, you can get translation at your docking site. And often with Elizarov, your overall alignment of your limb tends to drift a little bit into valgus, and because of the asymmetrical pull of the soft tissue and the tibia. And so I generally do transport with a hybrid frame. So I have an Elizarov segment with clickers over the lengthening side and hexapod over the docking side. We had one case that I showed there was a case from long ago that I did with a stacked frame, but yeah, I haven't done that much. It's too complex. You need 2 programs, like many other things. I have tried it. It's expensive. It's a heavy frame and too complex. You need 2 programs. So only in select cases. So mainstay for me is a hybrid frame. In my own cases, I just find that specifically long transport, difficult to get it that accurate, and you end up with an overall valgus alignment. But of course, if you are skilled and you can do that, that's definitely perfectly acceptable to do it like that. And obviously, Nandu, who's a more sort of better versed Elizarov surgeon than me. I know he does all his transports with the Elizarov, and then he does it very well. But doing it with a hybrid frame just allows you a little bit more flexibility in correcting deformities that you encounter. And I have a case now that I'll show you sort of my preferred frame setup for transport.
Fantastic. Thanks. And then just a quick question on RIA. What are alternatives now that we don't have RIA? I know we used it extensively for a lot. So
yeah, no, it's a disaster. I mean, there's no real alternative for that big volume. I mean, you can ream the outer table of the pelvis and just above the acetabulum, but that still doesn't give you the same volume. I'm also not so fond of that. You can use those big Cora bone harvesters, the sort of ones that's over 12 in the metaphysis of the distal femur and the proximal tibia, and do multiple passes. But even doing that from both legs, you won't get the same volume as RIA. So there's no real alternative for the large RIA volume that you have with RIA. It's a problem.
Fantastic. Thanks, Prof.
Cool. So just running through, there's a few more cases,
Sorry,
specific
Prof, one more.
Yes,
Sorry, Prof, one more question. Sorry. It's just a quick one on the previous complex case that Skulk so eloquently answered.
Yes.
It's just regarding the workup of that patient prior to the final fixation. Did you, because it sounded like it was quite a bad FRI, did you just, after the judicious debridements and patient optimization, blah, blah, and once you use targeted antibiotics, did you down the line do an MRI, or did you just use blood markers and x-rays? Like, how did you decide, okay, I'm happy here before you invest like all these titanium cages, retrograde nails, total hip prosthesis, etc.?
Yeah, it's very difficult. It's the same, always a scenario in when you do a second stage, whether it's for a stage revision of a PJI or for a stage revision of an FRI. I think the most useful is the clinical assessment. Unfortunately, inflammatory markers are less useful. So just clinical response to the treatment. I mean, she responded after the first stage. We had representative organisms. We had the same organisms or all our specimens. She had responded well to antibiotics. Her wound settled very quickly, and we did it at 6 to 8 weeks, the ideal time. And then the final sort of decision is just obviously intra-op when you open everything and there's no signs of ongoing infection. And then we sample as well, overlap 2 weeks of the antibiotics, and then stop if those samples are negative, which it was in her case. But yeah, so sort of response to first stage, mainly clinical, is the best measure to decide about second stage. I mean, you can't proceed with your second stage if you still have poor soft tissue, leaky wound, so forth. So clinically is the best measure. Okay, so just to run through a few specific scenarios, just in the humerus. I mean, for me, the options of the humerus, luckily you don't walk on your upper limb, is shortening. You can maybe consider masculine and very large defects. That's too large to shorten, but you can shorten almost any defect in the humerus. And I like to say that there's no defect in the humerus that's too big for shortening, and you can quote me there. Of course, you do have you use some function in the sense that you lose the mechanical advantage of your muscle, so you're not going to match the other side and sort of bicep curl weights, but these are severe cases, often mangled extremities, where the patient's just looking at some sort of function to just show you how much you can shorten. This is a case of a mangled humerus. Initially lots of bone loss, soft tissue injury, initially treated an external fixator, but then developed a non-union. Patient also had a upper plexus injury, so with chronic shoulder dislocation and no shoulder function, but fair hand function. So large shortening with him, and you can see from his little arm there, that is a sort of a 9-hole plate that goes from his shoulder to his elbow. But united, seen in his right arm, he's got no shoulder function, a lung condition, and good elbow and good hand function with a very short humerus, and that's much simpler. Unfortunately, a lot of the techniques that we use in the lower limb, like for instance bone transport, is not well tolerated on the upper limb, and you often, because of the many muscles, you get joint stiffness. Now, joint stiffness in the upper limb is a disaster, so shortening is much better tolerated than joint stiffness. So in the forearm, unfortunately, you are limited by the use of shortening because of its two bone and asymmetrical soft tissue. So shortening is very seldom an option unless you have symmetrical defects on both bones, and even there you can't often do much. Structural tricortical autograft works very well, and you can go up to a few centimeters, even 5, 6, maybe pushing for 7 centimeters, depending on the size of the iliac crest that you can harvest. This needs to be plated with lots of compression. And then there's also the single bone forearm technique that you can use in certain cases. So this is a case of a proximal radius ulnar fracture that was, you can say, also a little bit poorly plated, and at 6 months showing non-union with failure of the fixation, and revised that with the radius, which was simpler, just needed revision and some cancellous graft with a small partial defect, and the ulna a segmental defect of a few centimeters. You can see there this sort of area that's not so radio dense is the iliac crest structural tricortical graft. You need the graft responds well to compression. So in other words, you cannot just put the graft in and bridge plate it. You need a lot of compression. And there is the graft and the radius united. Single bone forearm, I'm not sure if any of you guys are familiar with that. So single bone forearm reconstruction is a technique that is described in defects of the forearm, where you basically plate the one of the forearm bones onto the other one. Specifically, it's classically described as transferring the distal radius onto the proximal ulna, and the sort of, or the longest one distally onto the longest one proximally, to sort of treat a bone defect. So you can see here in this paper from Rajasakaran from India, mangled extremity, large bone loss, plating the distal radius onto the proximal ulna, short little arm, but acceptable function. Now, I love looking at these Indian papers because we always think that we see a lot of crazy stuff here. And then look, now I have done a couple of these cases of single bone forearm reconstructions, usually with other people like Mike Solomons, and in this paper by Rajasakaran, they describe 38 of these cases. So it always makes me think I need to work a little bit harder and look for more complex cases. So this is one of my cases. The patient previously had a rollover injury, large segmental loss of the radius. It was complicated by infection, disrupted distal radial ulnar joint, progressive sort of deformity and pain of his trudge, and sort of progressive median nerve sort of symptoms. So we treated him with a single bone forearm. So basically resecting the distal ulna, transferring the radius onto the ulna, and plating. It's not as easy as it looks, because you obviously need to work through the plane between all the volar and the dorsal structures. And there's the patient at 3 months, sort of well on its way to union. Now, this, you can do many variations of this technique. Basically anything where you end up with a single bone in the forearm, you can call a single bone forearm reconstruction. This is another case of a mangled upper limb with segmental bone loss in the distal radius and the ulna, initially managed by another team that tried the masculate technique. You know, if you want to do masculate, you need very stable fixation. So you can see, and despite grafting the radius, the graft sort of resorbed and the X-fix was falling apart, and not much happening in the graft site there. Patient had a free flap, so at least he had good soft tissue. And then in this case decided that the ulna was the longest bone, so did an osteotomy and lengthening of the ulna, as you can see here. So lengthening, can't remember how many centimeters, until the ulna was in line with the wrist, and then did a carpo ulnar fusion, so fused the wrist to the ulna instead of onto the radius as you usually would. And there's the successful fusion with fair function for sort of devastating problem. Another sort of example in the same line, patient that spent 3 months in an X-fix with this terrible distal radius fracture with bone loss. If you look at that lateral, there's really only a few flakes of bone. Now, I mean, this is really pointless watching this for 3 months. You know, this will never unite. There's a large bone defect. And what we did here, myself and Dr. Maguire, we pulled sort of some of those larger pieces of the radius up, resected most of the distal radius, did a proximal row capectomy, and did a radiocarpal fusion, and this a resection of the distal ulna, basically ending up with a single bone, short single bone in the forearm, and sort of very good functional result at 2 years. This is a review article that Nandu and myself and other people wrote, just with all the different options, where it also described other options like bone transport, in the upper limb. So before I go to the femur, sorry, I missed question in the chat here earlier from, is it Yanga Nokwe, asking about, is deformity-assisted closure with gradual correction and lengthening an option? Yes, I'm not sure which case you refer to. So basically, deformity-assisted closure is a very useful technique. Lengthening, though, I'm not sure if you refer to distal lengthening. You should never lengthen for a fracture site. To achieve lengthening or regenerate formation, you need an intact periosteum and really sort of good soft tissue and not injured soft tissue or injured bone. So you can do a deformity-assisted closure and a gradual correction, but you should never lengthen at that fracture site. You won't get any regenerate formation. So you should set up a frame where you do a distant osteotomy and lengthen that site. I'm not sure if that answers your question. Okay, so in the femur, as I said, I mainly try and avoid circular frames in the femur. Only occasionally, if there's if there's a deformity present with a bone defect, I'd consider using it specifically in kids. If you do transport, and do it with a rail. I showed the masculate truss cage just earlier, which is really my first line treatment for large segmental bone loss in the femur. Just to show you, when you do transport the femur with a rail, how it can be done. So this is a pathological fracture in the proximal femur, secondary to chronic osteitis and a drug addict. So proximal femur, first the MRI, they're showing a large segment of bone involved. This is the first stage. So segmental resection of the infected non-union, and is the main spacer. And then applying a rail frame, in this case for distal to proximal transport. So you can see distal osteotomy and then transport of that proximal segment. The spine wasn't very reliable, actually disappeared for a few months mid-transport. And you can see here that he then came back with a lot of bone formation in what was the docking site, and we kept on transporting, but eventually got to a point where it just wouldn't move. There was already so much bone. But you can see here how those pins are starting to bend, but it united well, and we could take his frame off. So do bone transport on the femur, do it with a rail. The tibia, mascular is not a good option. Bone transport really is the mainstay. You can use hybrid technique for bigger defects to cut down on your fixator time. This is another example just of this patient had a bone defect and was treated first in an X-fix and then in a cast for 18 months following a fracture, and then referred to me with a non-union. I mean, this is not a non-union. This is an untreated bone defect, because you can't have this scenario and expect a union. So I would just say that this is not a bone defect that is not treated. So in other words, if you have a bone defect, you should have a plan to address it from the beginning. It doesn't help to just watch it. Osteoblast don't jump, and you're not going to get healing across a gap like this. So for him, bone transport, again, and to just answer your previous question, this is usually how I set up the frame. So you can see an Elizarov block with clickers. Clickers I just find are sort of more intuitive and give better feedback in the patients, and doing the adjustments just with the transport nuts or spanners, and it's a bit more user friendly. And here you're just lengthening in a straight line. So I do an Elizarov block with a clickers, either ring block short clickers or long clickers, just depending on the specific frame. And then I have a hexapod segment over the docking site. This allows you to steer the docking site and then to manipulate the docking site afterwards to firstly correct the residual deformity if it's present, but also compress the docking site if it's necessary. So this is how I usually do transport. And there you can see at the docking site. In this case, the docking site that wouldn't unite on X-ray, and then we sort of decided to cut down on his treatment time. What I would say, what you asked earlier about nailing afterwards. So my main decision is based on the pin sites. If the pin sites are pristine, even if the frame has been on for many months, I'm happy to do it as a single stage. I talk about the pin site history. In other words, if the patient mostly had pristine pin sites, no pin site infections, I'm happy to take frame off and nail in the same sitting. But in this case, patient's pin sites don't look great, so we first took the frame off, protected him in a cast. Very important. You can see here that your regenerate is generally consolidated. If you take the frame off when the regenerate is still not consolidated, this will shorten again. You shouldn't do it. Sorry, let me just advance the slide. So you can see here is in a cast, but the regenerate is already quite consolidated, and then converting that to a intramedullary nail. Someone has then their hand up on my screen here. It just says Galaxy. Who is Galaxy?
Yeah, sorry, Prof. That's me again. Just a question.
Okay.
When you do the clickers and the hexapod, do you shorten your docking site and lengthen simultaneously, or you do it sequentially?
No, simultaneously. So still transport. So the patients every day lengthen the osteotomy or the lengthening site a quarter of a millimeter 4 times a day with the clickers. But then the hexapod, they just adjust once a day. So they adjust the clickers 4 times a day, but they do the frame adjustment once a day. And in my experience, this is just the sort of most, for me, the most reliable and reproducible way to get, transport in a straight line, a healing doctor site without a deformity. So in this case, then nailing and then eventual union. So, what to expect is very important, that these are never 100%, cases. So you should expect success rate in 80 to 90% patients in appropriately selected hosts. So if you try and do these reconstructions on any patient, you're going to have a low success rate. If you select appropriately good hosts, you can expect 80 to 90% success rates, which is pretty good. And like, you should always ask yourself, what's the worst thing that can happen? So in other words, if someone has a situation that's relatively chronic and not a lot of mobility, and they're not a good host, rather leave them like they is, because once you go and you resect a large piece of bone, and your reconstruction fails, they can often be worse off than they were before you start treatment, which is against what we're trying to do. And then just to finish off with, I really like this quote by Andrew Mankin that said, all our successes are really just a reflection of the body's amazing ability to heal itself. So the take-home message really is that you need to include partial defects into your definition of critical bone defects. Anything that's not going to heal without intervention, you should have a plan to address it. You should know lots of different options, and you should know when to select the right one for the appropriate scenario. And there's really no, I would say there's no wrong answers, but there's no single right answer for any of these cases. And to quote Brian Bernstein, you always say, with these cases, the only person in the room that would be wrong would be the one that says only his way is the right way. Thanks. That's it from me. Any questions? Right. Okay. Everyone must have a good evening. Bye.
Prof.
Thanks,
Cool.
Prof.
Thanks a lot, Prof.
Thank you, Prof.
Thanks, Prof.
Prof.
Cool. Cheers, guys.